Hello everyone. So the next lecture in this series of breast is the benign breast diseases, and you must be knowing that 30% of women will suffer from benign breast disorder, and most common symptoms include when you see patient in either OPD or emergency or anywhere with complaint pain, lumpiness or a lump. There is a summary box in Bailey and Love which says that benign breast disorders can be classified on congenital disorder, injury, inflammation or infection related. So the congenital ones are inverted nipple, supernumeracy, breast nipples, non-busy breast disorder including teat syndrome, that is also called as costochondritis, and sebaceous cyst and other skin conditions of breast are also included in congenital disorders. Injury can be there which can lead to traumatic fat necrosis. I'll explain. Inflammation and infection related are ANDA, that is aberration of normal, differentiation and involution, cyclical nodularity and mastalgia, cyst, fibroadenoma, ductectasia or periductal mastitis are included in ANDI. There can be pregnancy related issues also, which are galactosile and lactational abscesses. Now, the congenital abnormalities, which include retracted nipple or inversion. You can see in the picture that this is the everted normal unretracted nipple, and this is the retracted nipple. It is a slit like retraction of the nipple. So it is bilateral in 25% of the cases, and retraction at puberty of unknown etiology. When it is horizontal slit like, it can be benign horizontal inversion, but in a patient who is saying that she is having recent retraction, so there is a significant pathological relation to it. The problems associated are definitely breastfeeding and infection because of retention of secretion, you can say, in the growth. Now, slit-like retraction of the nipple may be seen in ductectasia and chronic periductal mastitis. The treatment is usually unnecessary because condition may spontaneously resolve during the pregnancy and lactation. Simple cosmetic surgery may be giving a cosmetic result, but definitely it is having a drawback of dividing the underlying ducts. Mechanical suction devices are having some effect, but not very much useful. There is a term called amasia. You can say this. This is the normally developed breast of the left side. In the same patient, there is no development of the breast. So congenital absence of breast is called amasia. It may be unilateral or bilateral. There is a syndrome which is called as pollen syndrome. It is amasia which is associated with the absence of sternal portion of pectoralis major. It is called pollen syndrome. It is more common in males. There is also a term which is called as polymasia. It is supernumeracy of breast. So it can present from axilla till groin in this line, which is called the milk line. Axilla is the most frequent site for polymasia. Then it can be present in groin also, but again thighs also. They have been known to be functional during lactation, so they may produce secretions in lactation. So mastitis of infant is a term that is common in both boys and girls. There is a term which is called as witch's milk. So what happens in this is, on third or fourth day of life, if the breast of an infant is pressed lightly, a drop of colorless fluid can be expressed. After a few days, there is often slightly milky secretion which disappears during the third week. That is called the witch's milk. It is seen only in full-term infants. So it is caused by stimulation of fetal breast by prolactin in response to the drop of maternal estrogens, and is essentially physiological. The true mastitis which is seen in adults are uncommon in infants, and the true mastitis, you are aware, is called by Staphylococcus aureus. Now there is a thing which is called as diffuse hypertrophy. What happens in this is the breasts are usually enlarged. This is usually bilateral, but it may be rarely unilateral. It occurs sporadically in otherwise healthy girls at puberty. That is called as benign virginal hypertrophy, and it is much less often during the first pregnancy. It is caused by alteration in the normal sensitivity of the breast to estrogenic hormones. The treatment is with anti-estrogens, which is having some success, but the treatment which is helping is reduction mammoplasty. Now, injuries of the breast, the second group of classification, there can be hematoma of the breast. It is maybe giving rise to a lump when there is trauma to the breast, and there is lump due to hematoma. There is a term which is called the traumatic fat necrosis. This is also after trauma. It can be acute or chronic. It is commonly occurring in stout middle-aged women. A lump often which is painless appears following a blow or indirect violence due to contraction of the pectoralis major. It may mimic a carcinoma, even displaying skin, withering and nipple retraction. A seed belt may transact or avulse the breast with a sudden deceleration injury, which can be having the symptom of traumatic fat necrosis. Acute and subacute inflammations of the breast is the next group of classification, in which there is bacterial mastitis. It is the most common variety of mastitis associated with lactation in a majority of the cases. Etiology is, you know that intermediary is usually infant. After second day of life, 50% of the infant harbor staphylococci in the nasopharynx. That is, staphylococci is the main causative organism. The lactiferous duct will first become blocked by epithelial debris, which leads to stasis. Once within the ampulla of the duct, the staphylococci cause clotting of the milk, and within this clot, the organism multiply and infection proceeds. So, these are the clinical features. So, you can see this may be a pre-forming abscess. Now, we read the clinical features. Early generalized cellulitis, but later when it is localized, it can lead to abscess formation. The treatment is with antibiotics in early stages. By antibiotics which can be helpful are flucloxacillin or amoxicillin when there is cellulitis. But after there is abscess, you have to do incision and drainage. Feeding from affected breast may be continued. Breast support and analgesia will be helpful. Now, antibioma is a term which is given for antibiotic is used in a patient of undrained pus. This can lead to formation of a swelling that is called as antibioma. Incision and drainage, earlier advice was if infection did not resolve within 48 hours, we can do incision and drainage in the patient. New recommendation is even if there is abscess, you can do repeated aspirations under antibiotic cover. If it helps, it's good. If it is not helping, then again you have to go for incision and drainage. There is also tuberculosis of breast, which is comparatively rare and is usually associated with active pulmonary tuberculosis or tubercular cervical adenitis. It is usually presenting with multiple chronic abscesses and sinuses and a typical bluish attenuated appearance of the surrounding skin. The diagnosis is, you must be knowing that bacteriological and histological examination are very peculiar for tuberculosis of any organ. The treatment, you are again must be aware that antitubercular treatment is the first line of treatment. In some patient, mastectomy can also be done. restricted. The mastectomy is restricted to the patient with persistent residual infection. Actinomycosis is also a term which is happening in breast, but this is a rare condition. The presentation is characteristic of facio-cervical actinomycosis, but this is not very significant topic in relation to breast. But yeah, definitely in MCQ you can find out that one of the options is actinomycosis. That is why I have covered it. There is a disease which is called as Mondor's disease. This is the vein which is called Mondor's code. Let us learn what is Mondor's disease. It is thrombophlebitis of superficial veins of the breast and the anterior chest wall. So this is thrombophlebitis of the vein, anterior chest wall, and this is going into the breast. So it can also lead to thrombophlebitis of the breast, also known as string phlebitis. That is a string of thrombosed vein presenting as a tender cord-like structure. Cause is obscure in absence of any injury or infection, but pathognomic feature is thrombosed subcutaneous cord usually attached to the skin. So this is very clear picture of this. When the skin over the breast is stretched by raising the arm, a narrow shallow subcutaneous groove alongside the cord becomes apparent. So when you raise the arm, there will be a groove. Differential diagnosis will be lymphatic permeation from an occult carcinoma of the breast. Malignancy may be subsequental or coincidental, because we have seen some patients who are malignant, but it is not clear that is subsequent to Mondor's disease or coincidental finding with Mondor's disease. The clinical features are acute pain in lateral aspect of the breast or anterior chest wall. When you examine the patient, it is tender, firm cord-like structure will be felt, which follows the distribution of one of the major superficial veins. The diagnosis, definitely when uncertain or when the mass is present near the tender cord, a biopsy is indicated. Otherwise, diagnosis you have seen is clinical. Treatment is non-steroidal anti-inflammatory drugs are very helpful. Application of warm compresses along with symptomatic vein with restriction of motion and brachial support of the breast are important. When symptoms persist or refractory, we don't have any option than to excise the involved segment. Now, duct ectasia and periductal mastitis. What is duct ectasia? It is dilatation of breast duct associated with periductal inflammation. The pathogenesis is obscure again and almost certainly not uniform in all cases, although the disease is much more common in smokers. So this can be your MCQ question. So this is duct ectasia. The first stage is dilatation of one or more of the larger lactiferous duct which fill with the stagnant brown or green secretion which may discharge. These fluids then set up an irritant reaction in the surrounding tissue leading to periductal mastitis that can even lead to abscess formation or fistula formation. So this is the cracking. It is leading to fistula formation or abscess. Now in some cases the chronic indurated mass formed beneath the areola which mimics a carcinoma. The fibrosis in this usually develop which may cause slit-like nipple retraction which we have seen in the first slide. There is marked association between recurrent periductal inflammation and smoking. You have seen this. Etiology is contributing factor etiology is arteriopathy. Otherwise, some people believe that smoking increases the virulence of the commensal bacteria. Clinical feature are nipple discharge, any color, subareolar mass can be there, abscess formation can be there, mammary duct fistula and nipple retraction definitely can be there. Treatment is exclude malignancy first of all, then antibiotic therapy. The antibiotics, you know that co-amoxiclav or flucloxacillin and metronidazole are important. Surgery is head field operation, that is excision of all of the major ducts. It is important to shape the back of the nipple to ensure that all terminal ducts are removed. Now, aberration of normal development and involution nomenclature. You know that aberration of normal development and involution developed and described by Cardiff Breast Clinic. Etiology is, uh, first of all, we should know that breast is a dynamic structure undergoing changes throughout a woman's reproductive cycle. Superimposed upon this, cyclical changes throughout the menstrual cycle are there. Then what happens in pathogenesis? In this pathogenesis, this normal cycle is disrupted in breast physiology, extending from perturbation of normally to well-defined disease processes. Now, this is ND, which includes fibroadenoma, nodularity, simple cyst, and cancer is a different term. So, in fibroadenoma, you can see this. Around 15, there is starting of this, which peaks at around 30 and 40. Then it is coming down at around 62, 63 of age. Then simple cyst again at around 30. It is coming. Peak at around 50 years. Again 60 years. It is coming down. Now this is fibroid. I'm sorry. What I have to do is, so see the graph again. Fibroadenoma, nodularity, simple cyst, and cancer. So fibroadenoma starting at around 15 years of age and peaking at around 20-25. By 40 years it disappears. So after 40 years the diagnosis of fibroadenoma is very unlikely. Then nodularity, that is, you can see some female with nodular breast, that is not carcinoma obviously. So it is also coming at around 15 years of age, peaking at around 30, staying till 55, then coming at around 65, and it disappears after that. So after 65 of age, nodular breast can raise some suspicion. Again, there is simple cyst which is coming at around 30 years of age. The peak is around 40 and around 60 it is going up. But in malignancy, it is again coming from 30 years of age. But see, 40, 50, 60, 70, 80 and 90 years. So there is increase in the cases or the frequency of carcinoma after 30 to 35 years of age. Now, pathology is, the disease consists essentially of 4 features that may vary in extent and degree of any of the breasts. The cyst formation. Cysts are almost inevitable and very variable in size. The fibrosis, fat and elastic tissue disappear and are replaced with dense white fibrous tuberculi. The interstitial tissue is infiltrated with chronic inflammatory cells. The hyperplasia of epithelium is there in the lining of the duct, and acini may occur with or without atypia. Then papillomatosis. The epithelial hyperplasia may be so extended that it results in papillomatosis, overgrowth within the duct. The clinical features are definitely, the symptoms of AND include an area of lumpiness, which may be discrete sometime also, and or breast pain, that is mastalgia. A benign discrete lump in the breast is commonly a cyst or a fibroadenoma. True lymphoma rarely occur in breast. Lumpiness may be bilateral, commonly in upper breast quadrant, or less commonly confined to one quadrant of the breast. The changes may be cyclical with an increase in both lumpiness and often tenderness before the menstrual period. Non-cyclical mastalgia may be associated with ANDI or with periductal mastitis. Breast pain in postmenopausal women not taking hormone replacement therapy is usually derived from the chest wall, back or the neck. About 5% of breast cancers exhibit pain at presentation, but rarely as a sole presenting feature. Treatment of breast lumps, definitely our form assurance is important, because you have to convince the patient that it is not malignancy. It is perhaps worthwhile reviewing the patient at a different point in menstrual cycle, for example 6 weeks after initial visit, as often the clinical sign will have been resolved by that time. Rapid referral into secondary healthcare system often means patients are assessed without intervening menstrual cycle and may lead to additional concerns. Treatment of nostalgia, appropriately fitting braces and supporting to be worn throughout the day, and soft bras such as sports bras worn at night. Patients should avoid caffeine drinks. Patients should maintain a symptom diary, determine whether it is cyclical mastalgia or not. If reassurance is inadequate, the planned escalation of treatment should be advised. Oil of evening primers is having some effect in adequate doses given over 3 months help more than half of these women and appear to achieve higher response rate in those over the 40 years of age rather than younger women. Patients with intractable symptoms, antigonadotropins such as danazol or prolactin inhibitors such as bromocriptine may be tried, and they are supposed to be helpful. Very rarely an anti-estrogen, for example tamoxifen, oral luteinizing hormone, releasing hormone, that is LHRH, agonist may be prescribed to deprive the breast epithelium of estrogenic drive. For non-cyclical mastalgia, it is important to exclude extra memory causes such as chest wall pain, that is T syndrome. Treatment may be with non-steroidal analgesics or by injection with local anesthetics on a triggered spot. Now again, this is a table in Bailey Love for treatment of breast pain. What you have to do is reassure, adequate support, exclude caffeine, and first of all definitely you have to exclude cancer also. In medication, you are aware now, evening primrose oil is helpful, danazol 100 mg 3 times a day can be helpful, and tamoxifen is given some by some practitioners. So breast cyst, you can see it is a fluid filled cavity. It is most commonly in last decade of reproductive life as a result of non-integrated involution of the stoma and the epithelium. Clinical features are multiple or single cystic swelling which are palpable on breast. Diagnosis confirmed by aspiration or ultrasound. They typically present suddenly and cause great alarm to the patient. So the prompt diagnosis and drainage provides immediate relief. The treatment is definitely a solitary cyst or a small collection of cysts can be aspirated. If they resolve completely, nothing to be done. And if fluid is not bloodstained, no further treatment, definitely nothing to be done. However, 30% will recur and require reaspiration. Cytological examination of cyst is routinely not required. If there is residual lump or if fluid is bloodstained, a core biopsy or local excision for the cyst is done, and it is to be followed depending on the biopsy report. So other things are galactosile, fibroadenoma, breast abscess, that will be covered in future lecture because this lecture is already so lengthy. So grossly we can revise: investigation of breast lump after imaging performed. Cystic swelling, lump disappear, clear fluid, discharge the patient. That is after obviously finally the aspiration cytology. And residual thickening blood stain fluid. So investigate or do congenital biopsy when the swelling is solid, and if it is benign, on FNAC or for excision or observe, anything can be done. Atypical, you have to further investigate, either do congenital biopsy or excision biopsy, and if it is malignant, definitely treat for the cancer. Thank you so much. We'll meet again in next lecture.